there's only one method left, and that is something that's called a fecal transplant. So it turns out that if you make a nice slurry of feces and capture the bacteria and introduce the bacteria into patients, assuming this has come from a good, healthy fecal transplant patient, then that will cure C. difficile 95% of the time. There is something in the normal gut flora that stops C. difficile from growing. At the moment, we don't know what it is, but we know that it works really well. This is something that is being practiced in hospitals in the US. It's also being practiced in hospitals in the UK and in some places in Europe. Regulation of this is a little bit iffy at the moment. The insurance companies in the US are very worried that if something goes wrong during a fecal transplant, there will be a problem. But I love these next couple of slides because they also give you some indication of problems in the US. So Libby Homan at Mass General Hospital lent me these slides. And so of course you have to ask, well, how do you get the feces into a patient? And so she developed some gels, so you can isolate the feces, put it into a gel. Unfortunately, the first ones were translucent, which didn't do anything for the patients. No, that's a joke. It's a joke. In fact, you do not see what has gone into these pills. You take a couple of these, and usually one treatment is enough. Occasionally, you need a second treatment. Of course, one of the advantages is you minimize the risk of a bad aftertaste if you do it via a pill. And now, UPS, Universal Parcel System, they have this advertisement, what can brown do for you? Well, in the case if you have a C. difficile infection, brown can do a lot for you. And of course, you have to worry, wonder about what else. What else is there in the normal gut microflora that might be helping you? So this is just a list of why bacteria get such a lot of bad publicity, why people don't like them. These are all the nasty diseases that they produce. But in fact, I think we have to think of bacteria in a totally different way. So what's happened? Bacteria have made us their home. And when you buy a home, what's the first thing you do? Well, you surround it with a fence. You put a nice fence, maybe a moat up there. Maybe you put in an alarm system so that if something bad is going to happen, you keep off the invaders. And this is what bacteria do for us. Bacteria have no interest in our getting sick. They're only interested in protecting us. And we know that they produce compounds that will kill other bacteria. They will kill pathogens. We also know that they're capable of taking care of cancer cells. They produce anti-cancer agents. And I think the bottom line is, as we find out more about this, and if we can work out how all of this works, we really have the opportunity to both manipulate our current microbiomes, to make sure that our microbiomes are healthy. And the odds are we can do all of this without worrying about antibiotics, without getting involved in that. And I think we're going to be able to lower the costs of healthcare to a point where in the developing world, and this will become a very serious attribute, a very serious help for healthcare, and in the West too. So I thank you all for your attention.
Thank you very much indeed. I think it's very difficult for me to reflect in such brilliant presentation. So we will keep going, and then we will open the floor to have some reactions from you people to distinguished panelists. So the second speaker now we are going to have is Ahmed Goodfellow. So please, you have the floor, sir.
Good morning, and I'd just like to start by congratulating the organisers for putting together a very exciting programme, and I look very much forward to interacting with many of the younger scientists in the audience over the next few minutes. So what I'd like to do over the next few minutes is really just to give you a personal story of a journey that I guess that I've been through over the last year, and it's a journey really that describes how an academic, a non-clinical academic, which is me, sat here at my desk, who normally lives in a nice cozy office in Cambridge. This is the biomedical biomedical campus, working on viruses that cause gastroenteritis. Ends up spending somewhere in the region of 5 months, dressed like this, working in an insect-filled tent as part of the Ebola virus response in Sierra Leone. Now, as you've heard already, the Ebola virus epidemic that is currently and still ongoing in West Africa is the worst that we've seen. We've seen levels of intense human-to-human transmission that have not been recorded. The best estimates would suggest somewhere in the region of 28,000 suspected or confirmed cases so far, with approximately 11,000 deaths which have been attributed to Ebola virus infection. The good news is that actually the outbreak looks like it's largely under control in at least 2 of the affected countries, but sadly there are still cases of human-to-human transmission ongoing in at least 1. Now, this is an epidemiological trace of the number of cases across the outbreak from the start, from the first confirmed case in March 2014 until relatively recently. And as you can see, the peak of the epidemic was in October last year. In July and August of last year, I made a decision after close consultation with my wife that I would like to step forward and volunteer to help with the response. And I should say that as a non-clinical academic, the pathway from Cambridge to Sierra Leone was not straight. There wasn't an obvious path for someone like myself to be able to step forward and help in this outbreak. But eventually, as I'll describe over the next series of slides, I was deployed initially in November to establish and run a diagnostic facility, one of the first diagnostic facilities in the northern districts of Sierra Leone. I spent a period of around about 2 months there in total, and then subsequently from April until recently, and this laboratory is still running, we established a next generation sequencing facility within Sierra Leone to provide in-country genetic sequencing of Ebola viruses. So, as I said, I was being deployed as a team leader with Public Health England and also by International Medical Corps to work in an Ebola treatment centre in McKinney. This was one of the largest treatment centres, and in fact the treatment centre is still operational. They're going through a decommissioning process as we speak. This is the plan of the treatment centre as we were told that we would be greeted by. This is split into 3 zones. You have the red zone where the patients stay, the green zone which is largely where we work, and the white zone which is largely administrative. This is where the laboratory was located, which bridges the red zone and the green zone. And for those of you who don't know where McKinney is, this is McKinney. It's in a slightly northern area of Sierra Leone. It's a beautiful place. If any of you ever get an opportunity to visit, I do suggest it's a wonderful place to live and a wonderful place to work. When we turned up, the situation on the ground, I won't dwell on this image for too long, but just to highlight that the situation in McKinney at the time of our deployment was pretty desperate. The healthcare, this is an article taken from the New York Times, which really illustrates what the situation was like on the ground, but just to suffice to say that it was a very desperate situation. The healthcare providers were completely overwhelmed, and there was a real urgent need for treatment facilities as well as diagnostic capability. And in fact, the lack of diagnostic capability at that time really contributed to the intense spread of the virus, because it was taking anything between 4 to 10 days in October for a patient to be tested positive or negative. So we were deployed to McKinney. When we turned up, this is what we were greeted by. It wasn't built. The laboratory was still under construction. The outside of the shell of the laboratory was established, but the rest of the treatment centre was largely still under construction. So, as you can imagine, the first few weeks we faced a number of challenges in trying to establish the laboratory, establish the workflow, and get the entire process operational. This is our team. This is me. We had a relatively small team of 10 scientists, some from academic backgrounds, most of them from clinical backgrounds or diagnostic backgrounds. What you can see quite clearly here is we are not designed for manual labour. The most energetic thing I would do in my day is moving papers from one side of my desk to the other. However, in the first week or two, our job was simply to move equipment around the treatment centre. We had 3 lorries like this turn up all of which had to be manually offloaded by ourselves and packed into tents, and inevitably there were various injuries. But the team, we did, I think the team pulled together, we did pretty well. We then spent the next week or two trying to build the equipment, trying to make sure everything was intact, everything worked. Of course, logistics being as they are, some things didn't turn up. In the cases when things didn't turn up, we had to go to the market, we try and buy stuff, we had to try and make things, we do the same job. This is me with a piece of tape stuck to my forehead. But the end result was that we were able to put together a diagnostic laboratory as shown here. This is the opening on December the 13th. This was later than we'd hoped, but everybody was pushing and pushing in the right direction, but this was simply due to the resources not being in place. Some of our equipment hadn't turned up, but we officially opened. Our first samples were tested on December the 13th. Now this lab is still operational. It continues to operate at the minute. They've tested somewhere in the region of 15,000 samples so far. And the workflow looks something like this. A sample would turn up from, usually by a bike courier, and these samples include blood or swabs from patients that have passed away. They're handled by somebody like myself here in nice orange Crocs. We take them into what's known as a flexible film isolator, which enables us to work with the virus under controlled conditions to minimize the risk of infection. An aliquot of that sample is then taken, and the infectivity of the virus is neutralized using chemicals. The sample is then taken out of the flexible film isolator, and the nucleic acid extracted prior to the detection of the viral genome by real-time PCR. As I said, this lab is still operational, and I spent 2 periods of deployment over the last 12 months. I spent 2 months here running this laboratory. There were numerous challenges that we faced, as I said. One of the challenges, I live in Cambridge. We do not encounter spiders the size of your hand roaming around the laboratory. So getting accustomed to this sort of thing on a daily basis took a slight period of adjustment. The biggest challenge was, of course, the reality of the situation. As I said, I'm a non-clinical academic. I have no contact with patients whatsoever. The location of the laboratory and the workflow of the treatment centre meant that we were witnessing on a daily basis quite desperate events. And what we would see, certainly for a parent such as myself, I have 2 young children, we'd often see individuals such as these guys come in on their own. They're cared for by survivors, and you will either see them progress through the disease and come out as survivors, or unfortunately pass away. It was not, despite what happens in an Ebola treatment centre, I would say that myself and almost everybody who's worked there would feel that actually it's a very positive environment to work in. The overwhelming feeling you get there is that the national staff, the Sierra Leoneans and the international staff are there to do their best. They all work together. It's a very happy environment. And in fact, what you'll